right, welcome everyone, and thank you for being here to our common initiative between the RAMS, resident and medical students, part of SAEM, CDEM, and CORD. We all collaborated together with our esteemed colleagues to come up with this webinar on matching into EM, how we got here, and where we are going. Today will be very high yield for anybody going into emergency medicine, as well as any residents on this call who are in their emergency medicine residency right now. Our goal is to give you practical tools and advice and insights from some of the leading voices in academic emergency medicine as you apply to residency this year. We all fully realize that this is a very stressful time, and please be assured that it is for the PDs and APDs and everybody on the other side evaluating you, but I'm sure it's even more stressful for you guys as you go through this process with so much uncertainty and so many unknowns. So our goal today is to alleviate some of that anxiety and stress and provide you insights so that you can shine on your away rotations and on your virtual interviews as you apply to residency this year. So my name is Alexis del Vecchio. I am a starting PGY1 intern at Mayo Clinic in emergency medicine, completed medical school in South Carolina at USC Greenville. I'm also a member at large and on the board of the SAEM National Board, RAMS, and I'm also the RAMS liaison for the SAEM Virtual Presence Committee. As a way of introduction, this is a general outline of what we'll be discussing today. We'll have brief introductions from our storied panel that I'm very excited for all y'all to meet today. We're going to talk briefly about some of the origins of the SLO or SLOWE. How did it come about and why PDs and APDs felt it was necessary to have this letter that is very specific to emergency medicine. And we'll touch about, most importantly, about changes to the SLO this year, not so much changes as expansions and ways that perhaps PDs will be looking at the SLO differently or evaluating you in a different light or fashion in the context of COVID and limitations you may have to obtain SLOEs this year. With that in mind, we'll talk about how you can stand out in your EM rotations, or most likely your one EM rotation you'll be completing this year. And then we'll talk about ways that you should not stand out so you can get a good letter and do well. We'll talk briefly about the NISPE. Does it matter? The answer is yes, but we'll qualify that a little bit further. And then we'll try to give you some tips and tricks on how to do well on virtual interviews, which is going to be a very different enterprise than it would be if you came to visit a program in person. Then we'll talk about the future and how our panelists hope that they can improve the SLO and improve the application process, again, with a goal to reduce stress and make sure that everybody gets a fair shot to applying to residency. We'll end it with some parting words, advice, and insights and pearls from our panelists, and then we will open it up for discussion and questions from you all. Anybody who's on right now and watching, you're absolutely welcome anytime to post questions in the chat. If the question is pertinent to the discussion we're having, I may pose that question to some of the panelists. Most likely, most of these questions we'll keep for the end of the conversation. All right, so without further ado, I am super excited about this panel. We've been very lucky at RAMS on our webinars to have incredible guests, but I do think this is an exceptionally special panel. All of them have been involved in the SLO, either helping to create it, writing SLOs, evaluating applicants to residency and reading lots of SLOs, and this year have been involved, some of them, in submitting statements to update the SLO and create new SLOs in the era of COVID. I'm just going to be going down my screen, so if Dr. Gallahue, you could go first and just tell us a little bit about you and how you came to be involved in emergency medicine education.
So I'm the Council of Residency Directors in Emergency Medicine president, and I'm also the program director for the University of Washington. I have been involved with medical education since I graduated residency in 2001, and basically all in GME education. So I came out of residency and was an assistant program director and then an associate program director, and then I established the University of Washington program in 2011. So that's sort of my trajectory. I'm a New Yorker by birth, and training and raised. So if I speak too fast, please let us know in the comments because I tend to do that.
Thank you, Dr. Gallahue. Next, we have Dr. Jung, who it appears is in the Northern Lights, somewhere in Eastern Europe tonight. Why don't you tell us a little bit about you?
That's correct. I'm coming to you from Northern Finland. Actually, I'm here in Baltimore, Maryland, where we don't really get to see the Northern Lights. I'm at Johns Hopkins. I'm the UME director there, and I am this year's president of clerkship directors in emergency medicine. Like Fiona, I've been involved with medical education for my entire career. I took over our sub-internship in 2004 and then our core clerkship in 2006. And I've had lots and lots of roles in medical education, mostly at the UME level since then. And I absolutely love working with med students. And I'm really excited to talk to you guys tonight about the application process.
Thank you, Dr. Young. Next on my screen is Dr. Morrissey, who is frozen from my end. Oh, now he's not. Fantastic.
Oh, there we go. Is that better?
Yes, that's good.
All right. Thanks, guys. My name's Tom Morrissey. I'm a PGY 25 emergency medicine resident at University of Florida, Jacksonville. I'm really pleased to be here, but after reading some of you guys' backgrounds and pedigrees, I can't for the life of me figure out how I got onto this panel, other than maybe just the fact that I've been relatively actively involved in the development of the SLOR for the past few years, both as quite honestly a protagonist and an antagonist of it. And hopefully we'll be able to give you guys some insight into where it came from, what its goals are, and where it's going to, as you guys try and garner this vital part of your ARIS application.
Thank you, Dr. Morrissey. Dr. Lall?
Hi, everybody. I'm Michelle Lall. I currently sit on the SAM Board of Directors, really as the education advocate, I think, across the board. Like many on this panel, I started right out of residency as a medical student site coordinator, and then progressed to an assistant program director, an associate program director, a medical education fellowship director, and I've been part of two programs, both the Wayne State University Sinai Grace program in Detroit, and now back at Emory for about the last 7 years. So I look forward to working with this amazing panel and giving you guys some insights, and just remember, it's going to be okay. It really is.
Thank you, Dr. Lall. Appreciate this insight and all these introductions. So to start, let's speak a little bit about the origins of the SLOE. Anybody going into emergency medicine may be aware, hopefully all of you are aware, that the way to apply to EM is very different than any other specialty. We are unique in that we have this SLO or SLOE. It has evolved over the years and also has undergone some changes this year. Dr. Morrissey, why don't you start us off with how the SLOE came about, why it was necessary, and what are your general thoughts on that method of evaluation of students?
Yeah, sure. I'm not quite old enough to have been involved in the genesis or the origination of the original SLOR, the standard letter of recommendation, but I am old enough that I applied to emergency medicine before it existed. And I had one letter from a family practice preceptor that said, "You're going to love this student. He can go into a room with grandma and spend 3 hours in there and never once interrupt her. He's going to be the greatest emergency physician in the world." And I had another letter from a surgeon that says, "You're going to love this guy. He can retract for hours and not ask any questions and not bother you at all. You're going to love this guy in emergency medicine." And I still got in because in that day, few people were going into emergency medicine, and really all you had to do was sign up to get in. But it wasn't long before EM became a little bit more attractive and became a little bit more competitive. And we realized that those letters really didn't tell us much about the people that were going into emergency medicine. So a group of program directors and educators in the mid-90s got together and tried to put down on paper a template for what they really wanted to see out of the letters of recommendation for their students. And they specifically asked questions like, tell me about the student's commitment to emergency medicine. Does he really know what he's getting himself into with this job? Tell me about his ability to work with a team. because emergency medicine is much more of a team sport than, say, surgery or psychiatry. Tell me about his ability to develop quick rapport with patients, because we don't have much time to do that in EM. And that was really the beginning of the SLOR, was a templated letter to say, these are the things that we really worry about in emergency medicine. If you're going to write this student a letter, can you please focus on these characteristics, these facets? And that was a huge step forward in filling out a student's ARIS packet, such that programs that were interviewing them could get a feel for how competitive this student would be, and a little bit of how this student will fit in your program, because all different emergency medicine programs have very different personalities or very different flavors. There were some problems inherent with the original version of the SLOR, I guess. It was very prone to grade inflation. It had categories like, for example, it would say, tell me about this student's personality. Is it superior, good, no, superior, excellent, quiet, or good? And, you know, there's a lot of these characteristics that really don't fit on in boxes that well. Quiet may not be the best thing for somebody who comes to my program. Quiet may be a great characteristic for somebody who goes to a slightly different program. So what we tried to do in the next iteration was find ways to standardize that letter a little bit more. It was also very prone to hyperbole and grade inflation, and we took steps to find ways to kind of standardize that. So one of the next iterations of it was called the SLO, or the SLOE. We changed it from a letter of recommendation, which is what it really was, to more of a standardized evaluation. And we asked our educators to spend time with students and then answer those questions, but try and rank students in more of a, this is a top third, wonderful student, this is a middle third, great student, or this is a lower third, they're still fine, but they're going to take a little bit of extra work to come up to speed on this particular parameter. That brought a little bit more uniformity to the letter. You can argue whether or not that was a plus or a minus. There are certainly some drawbacks to doing it that way. There's some stigma that comes with putting somebody in a lower third, but it also, I think, brought a lot more ability to quickly read a letter and the ability to quickly get a feel for a student by going through that letter. The third iteration is where we are now, and that's the E-SLO. It's essentially the same thing as the SLO, but rather than people pinning them by hand and sending them out, they're all now loaded into an electronic database. And this does a couple of things. It allows you to track the letter writer's track record. So you can see if a letter writer is prone to giving, 75% of the people the top third, then you can read that letter with a little bit more of a critical eye. It also directly uploads letters into ARIS. So it removes the ability of deans or students to filter out bad letters, such that you get a little bit of a biased picture based on the letters that are selected. So that's the short story of how we got here with the SLO.
Thank you, Dr. Morrissey. Appreciate that. That was a very succinct summary, also very thorough of the SLOE. You mentioned, top 1/3 versus bottom 1/3. I think that causes a lot of stress and anxiety amongst applicants. It certainly did for me. I felt on shift, oh my God, there's two of us. Who's the top third and who's the bottom third? But you mentioned, and I know that Dr. Gallahue and others on the panel have discussed this as well, that there are stopgap measures in place, right, based on what you said, and previous letters and SLOEs written by different committees and institutions. So could our panelists speak a little bit more about that if you do get a bottom 1/3 letter, especially in the context this year of you may only have one letter in total, that does not necessarily mean it's a death sentence, right? I mean, there are options, and if anybody wants to jump in.
So I think I'm going to turn it over to Jules because I know she has a lot of ideas about this, but I just want to say that there are a lot of the SLOEs got revised this year in order to kind of address the COVID era, but some of them had been done before. And so the gold standard is the SLO, which is from residency training faculty. And when we say on the consensus document that is intended to have one SLO, that's the SLO we're referring to. There's another SLO that exists that is for non-EM, but for EM letter writers on a rotation that are non-EM residency faculty. There's a third type of SLO, which is a subspecialty rotation. So it's not the gold standard SLO, but it's where people can see at least maybe some of your interpersonal skills, but it's not really as much of a clinical evaluation. So subspecialty, so it's EM faculty on a subspecialty like wilderness medicine or ultrasound. And then there's a last SLO, which is a new SLO, which is the O SLO and another SLO. O stands for other. That's for non-EM faculty who work with you clinically, who know you well and can reference those traits that we were talking about of personality characteristics, teamwork personality characteristics, and all those other things. And that was, and both CDEM and CORD it wasn't a task force from CORD that basically created the SLOR and then the SLO and all the rest of it. However, really the clerkship directors are identifying all of these things that we really need, as well as the program directors. So we now have a committee that's not going to end because we really need to constantly revise the SLO to address really changes in medical student education every year. But there are 4 different SLOs. The gold standard SLO is the one for EM residency faculty, but there are other standardized letter evaluations that are now available for students to get these standardized letters. There's value to having the standardized letters because it decreases the inter-rater reliability. There's also a wonderful article from 2018 from Lee et al. In AEM Education and Training that actually talks about the fact that there's a lot of gender bias. If you look through a lot of literature, there's a ton of gender bias in narrative, the traditional narrative letters, and there's a lot of filler that's not valuable. What they found was that these the gender biased language that was used went away with the SLOE. So I think it's also a much less biased letter, much less filler, much easier to read, and target onto the areas that we care about. As far as the lower third, I'm going to hand that over to Jules because I know that she has a ton of ideas and she really works with medical students all the time in this situation.
Yeah, I do have a lot of feelings about that topic. So I'm looking right now, we have 112 participants on this call. That means that statistically speaking, 37 of us are in the lower third if we were to do some sort of comparative analysis of all of us, right? And I'm willing to bet, looking at my colleagues here on the panel, that I'm probably one of them. I want to emphasize that doesn't mean that those 37 people are bad people, are bad students, are ill-equipped to be doctors, or are ill-equipped to be emergency medicine physicians. We, in that lower third, are people who might just naturally have a slightly less steep learning trajectory when we develop new skills and internalize new concepts. We might be people who are less outgoing and flashy and don't necessarily dazzle our evaluators in the same way that more outgoing students do. We might be people who feel insecure, so we're reluctant to put our ideas out there. There's lots of things that might put us into that lower third, none of which have anything to do with our fitness to become doctors. So the notion of the lower third was never intended to be like, let's identify the people who shouldn't be emergency physicians. It was, let's identify the people who are going to need a little bit more help and get them to programs where they won't get eaten alive. That was the purpose of it, not ever to identify a large cohort of people that are not intended for this profession. There are some people probably who aren't intended for this profession, but it's not a third of us, right? It's a very, very small number of people who are going to have red flags raised high and waving at varying points throughout their careers. So please don't fear the lower third. It's not intended to be pejorative. It's just a mathematical reality that 37 of us on this call live there, and we're going to develop and get where we need to be just like everybody else will. We're just going to have a slightly different path.
Yeah, I think that's a very important point to bring up. And one of the examples I use when I'm talking with nervous students is, if you look at the language of the slow, we should not be writing these for people that we don't think are going to make it in emergency medicine. We're only writing it for people that we think are going to be successful. So it's analogous to taking the NFL. A third of the NFL players are by definition in the lower third, but they're all NFL players, and I wouldn't want to have to play football against any of them. So if somebody's writing you a letter, he should have already made it clear to you, I do think you're set up to be a success in this field. We now just have to find a way to match you into a program that is a best fit for your natural pluses and the places where you're going to need a little bit more guidance.
Awesome. That is extremely helpful. Thank you, panelists. And I think the big takeaway for everyone is that the slow is meant to help you. It is a tool that is meant to make you shine, or at least present you in the best light possible, while still being a letter of evaluation rather than recommendation. We actually have a great question in the chat that speaks to this, and something that Dr. Gallahue mentioned earlier that I'll bring to you all's attention. The question is, can the panelists speak on the role of the narrative letter of recommendation from EM faculty versus slowies from subspecialty or non-EM writers? Is one more valuable perhaps than the other, or if applicants have the option to have one of these sub-slows versus just a standard letter of recommendation? I assume that's what the question is getting at.
Yeah, I would say that those are very, I'm going to say something and then I'm going to have everybody like say, we won't maybe totally fall on the same line, but I will say a narrative letter is a really good thing when you have somebody who has a non-clinical letter to write for you. So if you have a research mentor or a college mentor or somebody who's known you really well, who's an EM faculty member who can speak to your non-clinical skills, which matter a lot. That's a great letter to get. So, you know, your research mentor, somebody who has a non-clinical letter to write for you. I will also say that it's probably best to have a narrative letter from another. If you already are getting a slowy from a site and another faculty member wants to write you a letter, probably narrative letter is probably the right way to go, quite honestly, because you don't want them to write a slowy and potentially write discordant information from the consensus letter, because that will undermine the consensus letter. So those would be two times where like a narrative letter is a really helpful thing. And probably bolsters everything, bolsters your application. For a clinical faculty letter, an OSLO is the best way to go. It really is. You want an OSLO from a clinical faculty who's seen you navigate some difficult situations or really advocate for your patients. Those are wonderful letters to get. I really care a whole lot if I see a general surgeon or an internal medicine doc or a family medicine doc or an OB doc who basically says this person went above and beyond for the student, who really understood sort of the non-clinical skills, was really empathetic with the family, or figured out some really challenging social situation to help this patient navigate things, or had a difficult patient and was able to navigate those things. So they're very different letters and for different reasons, and I think all of them can showcase you as a student really well.
The only thing that I would add to that is I would be very careful about getting a narrative letter from a faculty member at a place where you're also getting a slow, because even though you're not going to have checkboxes and ratings that would be obviously discordant, if the two letter writers view you differently and say different things about you, it undermines both. It really invalidates both. And it's also kind of viewed as double dipping, right? Like the gold standard of letter is supposed to be the ESLO from your main emergency medicine rotation at a place with an emergency medicine residency program. So getting two letters from that same experience is kind of not really the spirit of the law either. So I totally agree that if they know you in a different way through research or through community service or a leadership project that you did or your international work, there's lots of great things that a mentor could say about you. But if it's referring specifically to that month that your slow is about, probably you should let the slow writers, represent you and not have an additional person offering their opinion about that same experience.
Awesome. Thank you, Drs. Gallahue, Jung, and Morrissey. I think this is very important in clarifying information for the applicants. We've already sort of covered some of the changes to the SLOE this year and talked about subspecialty SLOEs. It sounds like, and I'm also learning myself from what Dr. Gallahue said, that essentially if an applicant is able to have one SLOE, the traditional SLOE on an EM rotation, and then do subspecialty rotations and get additional SLOEs, they're almost in the same boat as it would be in a previous year. If you're very nervous, as I would be, of, oh, I need to get 2 or 3 SLOEs, you're having something that is sort of replacing that. So if you could speak to that, that would be great. And along with that, we got an email question that speaks to that from an applicant who said, I was wondering if the panel could speak to how many SLOEs we should be shooting for this year. Is there a minimum or maximum number, and would having multiple SLOEs look poorly?
I think the first thing is we have a consensus document out there that says you should have one, ideally the goal is really to have one traditional SLOE. But there's other SLOEs that you can get, so I don't want to get confused. You know, like it's possible that all 4 letters could be, you know, SLOEs, but they're the different SLOEs of like the subspecialty SLOEs or other things. We also know that military candidates are required to rotate at 2 different sites. It's a requirement. There's a few institutions where they're required. So in those scenarios, it makes sense that they're going to have 2 SLOEs. It just needs to be explained well. But ideally, every single person has one SLOE from a traditional SLOE, so EM faculty at a residency affiliated training site. I see one comment that basically says if your medical school's affiliated hospital doesn't have a residency program and that's where you're getting your SLOE, that's where an away rotation is really valuable. It's really valuable because residency training programs really would like to see a SLOE from a residency training site. It's just a very different experience, and letter writers are generally better known in the community. So I would say that, you know, if you have 2 letters and you've got your SLOE and you've got a letter from your, you know, a mentor, that's not unreasonable. Usually 3 letters total is kind of a nice thing to sort of round out your application, but really we only expect to see one traditional SLOE. You don't need to have all 4 letter spots filled out.
And just to clarify, you know, when in the consensus document where it says you should be doing one home EM rotation, that's assuming that you have a home EM rotation that fits that traditional eSLOE paradigm. So if you have access to a home institution where there is a residency program where a residency faculty member can write an eSLOE, that's that kind of gold standard rotation. If you are at a med school that is not in that situation, it is perfectly acceptable for you to seek an away rotation at a place that does have a residency program to get that sort of definitive SLOE.
That's very helpful. Thank you. To speak to the second part of that question about the maximum number of SLOEs that you should have, speaking about traditional SLOEs, would you guys evaluating applicants this year may look down on an applicant who perhaps months ago, before all of COVID started, already set up a few different away rotations with traditional SLOEs? Would that be seen as, you know, taking away spots from others? And along with that, are there any exceptions? Are there any applicants that may need to get more than one traditional SLOE for a number of personal factors?
Oh boy, you've hit on a real hot button issue there. And I think this is probably the question that is causing the most anxiety amongst the audience out there. And we, even among this panel, were talking back and forth prior to this, and we don't all see things exactly the same way, although I think we all share the same spirit of the law. And I think what it comes down to is the idea is we have a limited number of rotational options this year. We want to make sure that every student gets one good rotational option. We want to try and level the playing field as much as possible. But we recognize that some students are in positions where the schools require more than that. Military applicants require more than that. Some folks may have a home rotation that technically counts, but really doesn't function very well as an academic rotation. So it might make sense for you to do another rotation somewhere. I truly believe, I want to believe that program directors are only going to look down upon you if you were hogging up other spots, if you were taking extra rotations to benefit yourself at the expense of other people. And I think program directors are pretty good at reading between the lines. But you can expect, if you've got a variation, somebody is likely to say, tell me about this other rotation. And it's fair to expect that they're going to be looking for a rational reason why you veered a little bit from the guidelines. And I think if you've got a rational reason for that, you're probably in very safe waters.
I think too that we all have to remember, particularly for those listening to us, that 15 years ago, people didn't do 3-4 away rotations in emergency medicine. You actually spent your 4th year of medical school seeing other things that interested you, learning in environments that would help you in the emergency department. So, I will say in pre-coronavirus times, I have seen many applicants sort of shoot themselves in the foot by doing 3 or 4 rotations where they were a star on the first rotation, and then on the second rotation, they were average. On the third rotation, they were only okay. So I think, just because this year you may only do 1 true EM rotation, if you can do well there, you're fine. There's a lot of us on this panel that have been reading these letters a long time. And if we see one good one from people we know, that means a lot. So I think, the points that Dr. Gallahue and Jung and Morrissey have been making is, yes, for those students who have to do 2 because it's the way their institution is set up, because it's the military, that's okay. If you are somewhere where you don't have a traditional academic emergency department to rotate in, then, part of the spirit of this is getting you to a rotation. And that means somebody else not doing 3. So I think, like we said, we're just trying to level the playing field so that it's equitable for everybody. But really, having 1 letter is okay. And sometimes having 3 rotations and 3 letters actually doesn't help you. So I don't want anyone listening to this to believe that last year that was the panacea, because it's not.
I so agree with that 100%. There was a comment about, from people from orphan programs of whether we are concerned about bias over their own students, like that maybe that if you're getting 1 slow and you're rotating your own students and you're taking other students, there's a comment basically, what are our concerns about bias for the students who are not from that school? And I would just, I would say by and large, most letter writers are really work hard to be equitable. Just to kind of address that concern, I would say often if you're from outside the institution, there can be certain advantages to that. Sometimes being at your own home institution isn't always a good thing. It can be a good thing sometimes, and maybe you have a leg up if the institution, you understand the system a little bit, but you also have many more times where you may have made an off comment to the wrong person by accident as a first-year student. And so on one hand, like, you're a fresh face and you have the ability to completely present yourself the way you want to. So there may be an advantage as well. And that sort of idea of, like, by the 4th rotation, sometimes familiarity is not always a good thing. And I will say, I by and large, letter writers really try to be fair. That's my own perspective. Maybe other panelists have other ideas.
I have 2 things to say about that. I mean, one is that I've been involved with CDEM since the organization was founded. I know, dozens of educators around the country really well. I cannot think of a single slow writer that would intentionally trash visiting students, in order to advantage their own students. Like, that is just not even, so if it happens, it's not happening at a conscious level at all. The one thing I will say, though, for students is I think it's wise for you, for those of you who do need to do an away rotation because you're at an orphan program or you're at a program that doesn't have an academic residency, choose where you rotate wisely. If you're at a place where you get 0 exposure whatsoever to emergency medicine in your curriculum, and you know, the very first time you set foot in an emergency department is going to be on this away rotation. Don't pick a place where the home students there, you know, start off doing shadow shifts in their first year and are acculturated to emergency medicine from the very beginning. Or like my students have a core rotation where they spend an entire month in the ED regardless of what specialty they're going into, because you're not going to be on a level playing field with the students that they're used to seeing there, because you just don't have as much experience. So pick a place where, you know, where you're likely to sort of have a comparable background to the students they're used to seeing. Pick a place that's going to be supportive of your learning needs. Like, we have an affiliation with one orphan program in our region, and those students are at a little bit of a disadvantage because they don't get as much background, but we do a boot camp for them, and we have like other educational offerings that we make available to them to kind of get them up to speed and enable them to shine during their rotation with us. So find places that are going to help you perform your best when you pick your away rotation.
Thank you, Dr. Jung. There was another question, which was, what if you have the opportunity to do an away rotation at a program you like in November or December, not to get a slow, but just for the program to get to know you? Would this year, knowing that spots are limited for most students because of COVID, would that be seen as appropriate, or would that be like a fine line to walk on? Anybody have any thoughts?
I think the question is, does it decrease the ability for somebody from an orphan program to rotate?
Mm-hmm.
If it's, say, a virtual, you know, rotation, or it's something that, or they're not accepting students for rotations, and I think it's not a one-size-fits-all.
Gotcha. I think that makes sense. Ruth, the other question was, if students have completed EM rotations as third-year medical students, and then they got a letter from it, a narrative letter, can they ask the person or the committee who wrote that letter to change it into a SLOE for the purposes of applying? And will you guys accept that for third-year EM rotations?
I think that'd probably be fair. Maybe a better option would be to do it as an OSLO. A third option, and this is something that I recommend students do when they're not really sure if somebody ought to be writing an OSLO or a narrative letter, is bring the formatted SLO to your letter writer, and talk to them for a couple of minutes about emergency medicine has this weird letter format, and these are the things that we're really looking at. And the program directors have made it clear to me that what they want to see is, does this guy know what he's getting into with emergency medicine? Can he handle things like uncertainty? Is he capable of taking a limited amount of information and thinking towards a provisional differential diagnosis and start thinking towards discharge planning? Can he work together with a team? Can he generate compassionate rapport quickly with patients? And if that kind of information comes in a SLO, an OSLO, a letter written on the back of a envelope, I'm happy with it. What I want to know is that somebody has looked at those characteristics in the student and can speak to having seen the student in circumstances that would test those characteristics.
Thank you, Dr. Morrissey. And that's actually a great segue into our next segment, which is something you've spoken about already, which is how the SLO evaluates students from a standpoint of their fit for the program versus objective skills and competence. I would love if you could flesh that a little bit further, and how the SLO allows you to evaluate both, and also how the paragraph you read at the end, the summary, how you address both of those for applicants applying to emergency medicine.
Man, how come my name's on this slide?
We can jump in if you know, at any point you can tag one of us and just point.
I
would love it if I could answer that question. But I am a big believer in fit is a key for maximizing success in residency. I think there are very, very few people who are just incompetent enough to not be emergency physicians. And I don't think there are any programs out there that aren't going to be able to train you to be a great physician. But I do think that if you can find a program that is a good comfortable personality fit for you, boy, you're off to the races. It becomes hard for us to stop you from becoming a good doctor. And that's why the external rotation has seemed so valuable to us for the past few years. Because if I see a letter that comes from a program that is similar to mine, if Dr. Lall writes a letter and says this person rotated up at Grady and they seem to be a really comfortable fit in a southern inner city safety net hospital, boy, that says the world to me. Whereas if I get a letter from a very academic center that says this person fit really well in our supercharged, research-driven emergency medicine house, I still think that's a terrific applicant, but it might not be the best fit for my program. And that's one of the things that we're really up against this year, is students aren't really going to have the opportunity to do a rotation at a couple of different styles. So we're going to be depending fairly heavily on having to read between the lines of the letters. This is one of the reasons why I think we're also grateful that we've been actively involved in CORD and CDEM for so many years, is because we get to know each other. We get to know each other's shops fairly well. And now I can look at the students who rotate with me and get at least a decent feel for which style of program they're going to be most comfortable with. And I'll be able to send them towards those programs. And hopefully, if I do my job right, I'll be able to write letters that will grab the ears of the people who work in those kind of programs. I'll be happy to have one of you guys dig me out of that hole.
To add to this, if I may myself, I think the personality fit is so important. As for my experience, Jacksonville was my dream program for whatever reason, I mean, for many reasons, but through medical school, and I rotated there and had a great experience with Dr. Morrissey and others, but I probably knew about 1 hour into my first day that, oh, there's no way I can do this for 3 years. It's a very county program. And I think I was good at faking it. I think I got a good letter. I have no idea if it actually transpired through the lines in terms of personality fit, but I ended up at a program that is the polar opposite of a county program and is very academic, and I couldn't be happier. And I really want to emphasize this point for our listeners, that you don't want to be someone you're not when you're rotating. You want to make sure that you present yourself and you identify a program, since you only have one away rotation, where you feel you're going to be happy, because it's going to be 3 years and 3 intense years. And I think it took me a while as I went on interviews to understand, what is this personality fit? What does that mean? And a lot of it is learning fit. Are you someone that learns by being thrown in and sort of learning as you go? Or are you someone that perhaps wants more guidance and didactics? And programs are very different between each other. And like Dr. Morrissey said, they all know each other as well. So they know if you get a letter from a certain program, their program is similar, and they will look at that very carefully.
Yeah, you're absolutely right on that. There's no question that you would have excelled everywhere. But if you find a place that is a really comfortable fit for you, you're also going to sleep a little bit better. You're going to stay healthier. You're going to have time for more social life. You're going to be able to launch your career a little bit better. And it's really hard to figure out that fit. There's been a couple of comments that have come up in the chat that says, tell me a little bit about what the fit parameters are. What should I be looking for? And I'd love to hear from my colleagues. But the couple of things that come to mind right up front for me are, some programs are much more formal than others. Some are on a first name basis, and some are yes sir, no sir, Dr. So-and-so, this is a protocolized way of doing things. Some are very hierarchical, where the interns only present to the seniors and the seniors are the only ones who present to the attendings. Some are much more casual and relaxed, and anybody can talk to anybody. Some are much more dive in early, get a lot of clinical exposure right up front, really cut your teeth in that first year, and then spend second and third year refining things. Some are a much more gradual ease into responsibility, and third year is spent really running the department. So your first year versus your third year may be your most intense year. Gosh, I wish I could really give the students, the applicants out there in the audience, a simple 3x5 card formula for ferreting this out. I do know that a lot of programs are putting on online programs, sneak peeks, virtual visits over the next 2 to 3 months, where they will have their faculty and their residents come on and talk a little bit about hospital format, learning style, educational responsibilities, ramp up of responsibility. And those are probably going to be as valuable as just about anything. That and picking the brain of your advisor to be able to answer.
We should develop a BuzzFeed quiz to help students identify their residency program style. We'd make millions.
Well, and I would also be very cautious about, like, you know, taking anybody else's word for it. You know, it's interesting how different perceptions across the board, and, you know, you see various social media platforms where people say one thing about a program and somebody else, their perception was a completely different animal. So I think going to those types of town halls and getting your own feeling for those programs that you might be interested in is probably one of the better ways to learn.
I would agree. And I think this year for you guys, it's going to be really important to do your homework. Like, you really need to be on everybody's websites. You need to be checking out their Facebook Lives, whatever other social media pushes they're trying to do, so that you could, you know, get a better idea of what the programs look like. I will say, as somebody who's done interviews for a long time, it's really apparent who has actually really kind of researched your program and who hasn't on interview day. And this is not the year to be that person who has done no research. So really try to use the resources that are available to you so you can, one, be an informed applicant, but also, you know, really be make informed choices about where you think you might want to go. And it's okay that that's maybe not the same as your best friend who's also doing emergency medicine. So I think Dr. Gallahue's point is super important, that you really need to take everything you read online with a grain of salt and do your own research.
One good option might be to call your buds who graduated last year or the year before. And if you don't have friends, go to your clerkship director or go to your dean and ask them who went into emergency medicine last year and try and get a hold of those guys, because they will remember the interview trail. They may be able to tell you a little bit about the feeling they got from the interview day from several different programs.
Thank you all. I think this is very valuable and reassuring advice for our listeners. I will add that SAEM RAMS is putting on a virtual residency fair July 27 through the 29, and we have greater than 100 programs that have signed up. You can sign up on the SAM website, and I will mention this again at the end of the chat. This is an exceptional opportunity to put yourself out there, get to know programs, perhaps in even a better setting than you would at one of the fairs where you may only have a few minutes. In this case, you'll have half an hour, 45 minutes to hear directly from PDs and APDs. So I highly suggest and encourage you to take advantage of that. I think we've spoken a little bit about this, bottom 1/3 evaluations. Dr. Lall, I think you have some thoughts about coaching with regards to this. And if you do have to write a bottom 1/3, as we said, it's not the end of the world. It doesn't mean you won't match. But how do you approach writing those? And how I can see we have some advisors as well on the line, and some that have less experience with emergency medicine. How do you approach those students, and how can they improve if they turn out to have a lower, middle or bottom 1/3 slowly?
So, I think the question really becomes, and certainly what we look at when we're writing our letters, is what was the reason for the bottom 1/3? Because as Dr. Jung said earlier, right, a third of us on this call are the bottom third, if you want to slice us or dice us in some way or another. So for some folks, it's really an issue maybe about fit. I practice in a really high volume, high acuity urban center. And some people thrive in that. I'm going to throw you in head first. Maybe I'll throw you a life preserver. Maybe I won't, but you're going to make it. And some people don't. Some people, that is not the way they learn. And that's absolutely fine. But maybe at my program, they're a bottom third because they are not a good fit for us. And they were not maybe as successful in the rotation because they were uncomfortable, because we were teaching them in a style or a method that doesn't work for them. I think a really important thing that I think all the other panelists would agree is that this is why for any faculty member on this this webinar also, we have to be very honest with our students about where their strengths are and where they need to improve. And not everybody's learning curve is, you know, on the same trajectory. Some of us take a little bit more time to learn new skills. Some of us will just go for it and keep our fingers crossed that we don't mess it up, right? We're all different individuals. But I think it's really important for students to have an understanding of things they could do to improve. But I also, you know, I also think, as was said before, a bottom 1/3 does not mean you're not going to be a phenomenal emergency medicine physician. You know, this group of you who are applying are exceedingly competitive. You know, reading these applications, I think a lot of us would say we would never get into residency now if we had to apply. So, you know, you guys are a really strong group. And I think that we all do our very best to be honest. And I think it's been mentioned before too, that most of us know each other. Or if I don't know someone directly, I know someone else who knows them. And I think we do a really good job as a specialty trying to get people to the place that is best for them. All we want to do is train great doctors.
Thank you, Dr. Lall. I think this is great information and great insight. Let's speak a little bit, and we've covered some of this, but what are some ways that applicants can stand out on their most likely one EM rotation this year? Or what are some specific characteristics that you're looking for, or even specific examples of some students recently that really stood out from the pack and you know, resulted in a good or great slow week? I'm going to open this question to the entire panel.
Can I just say something that really impressed me recently? Working with a student asked me how I wanted to be addressed. And, you know, it was nice because we talk about sort of types of programs, but even your different faculty are a little bit different. And I think it's really nice, you know, it's because if a student is humble enough and thoughtful enough to ask me how I want to be addressed, they're going to do the same thing for their patients. And I think it's really, really valuable to know that people approach patients and understand that they want to be approached differently. And I thought that was just one really, really nice thing to see. And then I think the other thing is, how do you like to work? You know, do you want me to work more independently, and how far do you want me to get with my workup is also a really nice one, because I get a little, I don't want my medical students usually going too far down without guidance. But I recognize that there's different styles.
I'm glad you said that. That harkens to my stock answer for this question. I see people who show up and they want to impress me with their depth of medical knowledge, their speed, their mastery of procedures. And in the back of my head, I'm thinking, wait a minute, that's what I can teach. What I can't teach is the EQ stuff, the stuff that your grandma should have taught you. Are you polite with people? Do you have an internal driver for success? Do you have a strong work ethic? Do you just come to each shift wanting to learn something new and be a little bit better? And if you can show me that, I'll take a whole residency full of those guys with slightly lower than average board scores, slightly lower than average efficiency ratings. But man, they get it. And they're going to get along with their colleagues, and they're going to get along with their patients, and we can teach the rest. That's what I look for in a student. That's what impresses me the most.
I would agree. I think it goes such a long way just to introduce yourself. You know, sometimes our teams at Shift Change are really big and the student won't introduce themselves. And I won't have any idea until we've already rounded who everybody is. And I think too, it is those small, thoughtful gestures. You know, if I watch you walk past a patient who's yelling out, "Hey, nurse," and you don't stop, that hurts my soul, right? We all went into medicine to help people. And sometimes the help we provide is not necessarily medicine, right? Some days I'm the most senior person in that department, and the best thing I do for somebody is get them dry socks and a juice. And you just have to understand that that's part of what we do. So, you know, show up early, right? On time is late in emergency medicine. So please come early, and don't be afraid to introduce yourselves to us and tell us something about yourselves. I know one of the faculty I work with at Emory, he always asks, what's one thing you want me to remember about you today that has nothing to do with medicine? And I know it's a memory cue for him to be able to remember students, you know, and let you guys stand out. But, you know, pay attention to some of those small things. You don't have to be flashy. You don't be the loudest person in the room, but, you know, let us know who you are and let us know that you're there.
I totally agree with everything everybody has said about I like the way Tom put it, the EQ stuff, right? I think that, you know, we all notice the student who like sits at the nurse's station reading up to date versus the student who gets up when one of the nurses is struggling with a patient and helps them, or the student who gets up to check on their patients and make sure they're comfortable and informed. Like, we notice those things, and they're incredibly important. On the cognitive side, one thing, and I'm curious what the other panelists think, but one thing I really like is a student who's not afraid to be wrong, because emergency medicine is not about having an encyclopedic knowledge of all things, because fundamentally, literally anything can come into the emergency department. You're always going to reach a point where you are at the end of your book knowledge, and you've got to use intuition and reasoning to get yourself through a problem. So I don't care so much that my student knows the right diagnosis for the patient. I care that they're able to obtain data and filter it in a way that makes sense and formulate something like a reasonable differential. And if they happen not to have included the right answer on that differential, that bothers me a lot less than the student who's unable to formulate that differential because they're so afraid of saying something wrong. So for me, at least, if I have the pleasure of working with any of you, I really want to hear your reasoning. I want to hear your thought process, because then you're giving me something I can work with and something I can help move you forward with. Whereas if you're just focused on dazzling me with your amazing knowledge, like, first of all, it's probably not going to work, because fundamentally, you haven't had a lot of experience yet. That's not what I want to see. What I want to see is that you can reason and you can think on your feet, not that you're always going to be right.
The other thing is, one of our sites is a tertiary quaternary care hospital, and it's not uncommon that we have some patients who teach me something because they know more about their disease than pretty much anybody. I think if you've had that conversation with a patient like that, it's really valuable to bring that up in the conversation of, this wouldn't be on my differential. However, my patient mentioned that this is exactly what happens every time, blah, blah, blah. It's really nice to hear that you're listening to the patient, and it's a strange symptom, but they've had it before. And
thank you all. This is very helpful. Not to belabor the point, but as written on this slide, just to emphasize this, one rotation, one slowly this year is enough. Believe it. We would not say it if we didn't mean it.
One more thing I might add to this particular slide, though, is still be yourself. Be a really good version of yourself. Be the version of yourself that you would want your mom to see if it happened to get videotaped and sent to her. But be yourself, because you may be able to put on airs for a month. You may be able to fool yourself and fool other people for a month, but the real you is going to come out during residency. So it makes sense to bring the real you to your rotation.
Thank you, Dr. Morrissey. So we spoke about ways to stand out on your EM rotation. Briefly, we'd like to speak about ways not to stand out on your EM rotation. If our panelists could share stories, being HIPAA compliant and not mentioning specific names, and perhaps stories of applicants who didn't realize that they were messing up or did things to annoy or bother, or they came off a way they didn't realize they were. Anybody wants to jump in? I know this is a little bit sensitive and tricky.
So I've got two things. I mean, you guys, for anybody who's not monitoring the chat, I cannot overemphasize the importance of being kind and empathetic and treating every single member of the team with respect. Because if you say something rude or dismissive to a coordinator or a security guard, or somebody that you perceive as not being an important member of the team, there's a reasonable chance that'll get back to us. And I don't care how good your application is, we're done with you at that point. So I cannot overemphasize the importance of bringing the same respect that you bring to the attending to every single other person you interact with. So that's one. The other one for me that I think is really important is, how do I put this right? Sometimes students, you know, they kind of want to get into the ED culture. They want to be part of the team. They want to be part of the gang. And they kind of adopt some of our slang. They adopt some of the terminology that we maybe use when we're not being our best selves, when we're feeling frustrated about particular types of patients, or when we're feeling overwhelmed in certain situations. And it's not good behavior. So even if you hear other people on the team referring to patients in ways that are less than flattering, or making comments about, dismissive comments about, you know, this guy doesn't need to be here, or this is nonsense, or whatever, just remember, A, that we're not always our best selves, and sometimes you're going to hear us say things that aren't right. And two, that communication is relational, right? So somebody I've worked on a team with for 4 years, and I know their real self, they can say something to me in a moment of frustration, and I'm not going to interpret it as, oh, this is a bad person, or this is somebody who's not patient-centered. Whereas if a student emulates that behavior and says that same thing to me, it's going to be a red flag. So I think you want to be really careful in the language that you use and the attitudes that you present around patients and team members, especially regarding those types of patients that we care for in emergency medicine that can be particularly challenging or frustrating.
I would re-emphasize that, you know, we take care of a lot of vulnerable patients. And I think one of the greatest fears that every faculty member who works with a student is afraid that, it's a privilege to take care of the vulnerable patients. I think all of us believe that. And if there's something that indicates that you are not empathetic to our more challenged people, I think it's a really hard thing to recover from. It matters so much. I think the same thing for consultants. You know, sometimes our consultants may be having a bad day, but please don't badmouth the consultants. You know, I think that's the other part of it is language matters. The language we use around each other matters. It's really important that as being part of the team, we can't be tribal. It's not EM and everybody else. We're all in the same playing field and we all matter. And so I think, you know, if you do something that indicates that you don't understand how important every member of the team is, how important our patients are, how difficult some of our patients' lives are, I think that's just like, that is really hard to recover from. It just is. So I think those would be some really ways to do that. I think the other part is don't harm your patients. I think one of my hardest days ever was having a medical student who had decided that they needed to place an IV, and they had actually stuck the patient 19 times. And I just happened to find out because I was, you know, I pulled back the curtain and the medical student's like, so-and-so is a great trooper. I keep sticking them. And I had to walk away because I couldn't, it's heartbreaking when in the attempts to do the right thing or trying to participate, you harm a patient. That's another thing that's really hard to recover from. Think about your patient's experience. It just matters so much.
Know that we have eyes and ears everywhere. Every year, somebody who we all think is the best thing since sliced bread slides down to the do not match version of the list because of an email that we got from a nurse, or because of an email that we got from a clerk that saw them pull the curtain and teach the patient a lesson. Yeah, you got to be on 24/7, 365 when you're on your rotation. You got to be on 24/7, 365 to be in this field.
Thank you all. This is great advice. And to add to this, the great opportunity that everyone has this year is you only have one rotation. So you only have to be on 24/7 for a month. I can tell you personally, having done 3 rotations, by halfway through the second one, you are exhausted and you feel burned out. And it is exhausting, even though you should always act that way in your life. You know that this is high stakes and you really want to put your best foot forward. So you have a great opportunity to be on, but for a limited period of time. This seems to be a good segue, speaking of being on and being evaluated, to the MISPE, or the Dean's Letter. The question being, does it matter? And the short answer is yes. Really, the question we wish to address here is, how much does it matter? Especially in the context of, with emergency medicine, we have the slow we. So if our panelists, including Dr. Gallahue and others, could speak to this, and how much of an asset is it for applicants? How much attention do you give to it versus the slow we? Where does it sort of fit in your holistic approach to evaluating applicants? And with changes to the COVID landscape this year, do you expect that the MISPE will have a different place in the application process as you evaluate applicants?
So just so everybody knows, the MSPE is the Medical Student Performance Evaluation that's done by the deans. I think it depends on the MSPEs. Some of them are really, there are MSPEs that are about as opaque as you can get, and you're just impossible to read them. And then there are MSPEs that are really, that are fairly objective and thoughtful and well done and easy to read, and show clinical score breakdowns and include narratives that speak to people's skill sets. So I would say the MSPE matters depending on who writes it, and that's not something you have any control over as a student.
Yeah, I also think it varies a bit program to program. I think there are certain programs who frankly probably don't look at it because, as Dr. Gallahue said, there's such variability based on the medical school with regard to what information is in there. But I do think that some programs, I think, look at them pretty carefully. If you were a superstar on your EM rotation, but every single one of your other rotations is average or below average, why is that? And I do think it raises some concern potentially about effort in subjects you're maybe not as interested in. Because remember, we spend a lot of emergency medicine residency training not in the emergency department. So it's important to be able to perform well with other specialties. But again, some of these letters are really insightful, really thoughtful, and some of them really are not. And as Dr. Gallahue said, you can't really control that as a student. But there's nothing better than you've read through an application, you're like, wow, this applicant is amazing. You get to the MSPE, you're leafing through it, and you're like, wow, they really did well on all their rotations. Then I think you feel like you're making a pretty safe bet offering that person an interview. There's probably not something hiding somewhere else.
100% agree with that. It's interesting though, some schools there's like 90% honors, and then you just raise, or there's a couple schools that are now going past fail for all the clinical scores, and that makes it really, and the narratives all say the same thing.
Dr. Gallahue, this is a great segue into Dr. Morrissey. I see you unmuted yourself. Go ahead.
I was just going to say there's not much you can do about your MSPE, but there's usually a narrative part up front that introduces you. And if you happen to have something in your background that would speak to one of the big components that we look at in a SLOR, the ability to take on personal responsibility, or the ability to work with and lead a team, you might want to mention that to your dean, because they can work that into the introductory part. And the other thing would be to not completely shirk your duty of proofing the MSPE and making sure there's not mistakes, because sometimes mistakes do happen. Schools are trying to put a lot of these things together, and a good quick proofread will prevent a program director from coming across a goof and holding it against you.
Thank you, Dr. Morrissey. Dr. Gallahue, what you mentioned is a great segue into a related question, which is that there's obviously a lot of uncertainty for applicants this year, and hopefully we've done some to alleviate some of the anxiety that results from that. But there's also uncertainty from your end, evaluating applicants, in that there's much fewer data points in terms of fewer letters. Some applicants that might be on this chat right now may not be able to take step 2 until after they've applied, if wherever they are, the prometric sites are closed. Some of the, as has been mentioned already, some of the medical schools decided to go to an entirely pass-fail system for all of third year, especially if you have not been clinically rotating. It wouldn't make sense to be evaluated on your clinical skills. So how is that going to change the way you approach evaluating students? And also, is that going to therefore give even more weight to the slow within this context?
I think when a student has pass-fail clinical grades and narratives that sound very similar, so there was a question about what is a bland narrative, and that's, it's basically like what happens is we generally will read more than one letter from one school. So there's often more than one EM bound student. And what happens is when you read the letters from the same school and they're basically almost identical repeatedly, that's a bland narrative. And so what might be bland for one might not be bland for another. Worked well with others kind of thing may be specific in one scenario, but it may not be specific in another. I think that when people describe very specific behaviors, medical student X, constantly showed up early, constantly looked up all of their patients' narratives, called family members, those kinds of things. It's a very specific type of behaviors that we're looking for. Remediation is one of the hardest things we do. I don't think there's it takes years off our lives. Every time you have to go through a significant remediation, especially if it's a professionalism issue, it takes years off of our lives. I don't know how else to say it. So, it makes us very anxious. And when we see the MSPEs that basically reassure us that you care about humans, you do the work, and you have a strong work ethic, and you will learn these other things that we can teach you, that is hugely reassuring when we decide to use one of our limited interview spots for you. We're looking for reassurance that you will not be an outlier on the professionalism score, more than anything else. And I will say that many medical schools there is a conflict of interest. They want you to match at any cost. And more we're seeing that where very specific situations don't get mentioned or concerns don't get mentioned in some MSPEs in some schools. So I think that's when we're talking about sort of like each application looks a little different, each MSPE looks different, but what we're looking for is to please have any reassuring commentary that you can give us, because we don't have a ton of time and resources to fix big problems. We can teach you so much about the medical knowledge and the procedures and all of those things, and we want to teach you those things. But if you can't speak nicely to others and you don't value humans, it's really hard for us to work on.
Thank you, Dr. Gallahue. This is fantastic. Since there are fewer data points this year, or relatively speaking, there are fewer, are any of you going to consider step 2 scores, step 2 CK to be clear, more highly than in previous years? Or will you use that, or is that going to have more importance? Or should students just strive to do as best as they can on that test? And likewise, if there are applicants that are not able to get a step 2 score in before they turn in their application due to reasons entirely out of their control, such as prometric sites being closed and long waiting lists, especially with COVID increasing in some areas of the country, will they be at a disadvantage when applying?
Here's the thing about USMLE tests. They predict your ability to perform well on other tests. So they do accurately predict your ability to perform well on your in-service exam and ultimately to pass your board certification exam. That's legit. Like Dr. Gallahue said, she doesn't want to die 5 years earlier because she's remediating a student who can't pass their exams, right? So if we see somebody who really struggles with board exams, that makes us worry. But beyond that, there's not a lot of correlation between the performance of a person as a doctor and their board scores. We've all had students with marginal board scores who are amazing clinicians, and we've all had students with 265s who are a disaster at the bedside. So, I think we look at them and they're a metric of your sort of overall academic ability, but it's not a standalone make or break type of number. Would you guys say that's accurate?
I would agree.
Yeah, I was just typing in that I cannot tell you how many of my rock star chiefs and the people that I hope to hold on to as faculty that have some bottom third dings in their letters of recommendation and subpar board scores, but they are just stellar human beings, and that's what makes them great doctors.
And I can't tell you the number of people I've interviewed who they're clearly on the spectrum when they've gotten some of those top scores that are going to be challenged to interface with some of our patients.
Yeah, not to say that everyone is. So if any of you guys are sitting on 265s out there, don't be freaked out, you know, but just know that it's not a standalone metric one way or the other.
And I mean, we all certainly recognize how challenging this time is. I mean, I don't think anybody, you know, will say, well, I don't believe you couldn't get a time at a testing center. I mean, we understand. I have residents who should have taken step 3 a long time ago that still can't get scheduled for it. So, you know, we all understand that this is, you know, a challenging time. I think it's something, if you're able to do it and you get it done, great.
Yeah, I mean, we can't even get our hair cut, so we understand that you can't.
I think maybe the takeaway from all of this, I hope you've heard from all 4 of us, is that there's no one thing really, unless it's really unprofessionalism or something that's probably unremediatable, that's going to tank you. I think it's easy to have some anxiety around maybe not doing well in step 1, in which case maybe step 2. For everything, most of everybody is going to do great, and all of you have these various aspects of things. So I just, please know that we are looking at all the information that's available to us and not looking to tank people.
Thank you all. This is great advice. I think one of the takeaways from tonight is that everyone on this panel, and for our listeners, all the PDs and APDs and faculty you'll be working with at your home institution and away rotations, really wants you to be successful and has your back. And if you work hard and you present the best version of yourself possible, you're on your way to matching at a program where you'll be happy. And it's true this year, and it's been true in previous years as well. Moving on to virtual interviews, which I'm very excited to speak about. Again, a lot of uncertainty here from both ends, since neither programs have, for the most part, engaged in that, except for what used to be the virtual interview requirement, which we don't have anymore, and we don't need to get into that because that could be a long conversation. But so how can students stand out on virtual interviews? What are some do's and don'ts and red flags as well? I will open this to the entire panel to chime in on their thoughts.
I mean, I think this is a lot of the same things as a regular interview day. Like, be polite, be poised, be groomed, be kind to everybody that you interact with. I think this is going to be new for all of us. I'm sure we're all going to have some Zoom hiccups or whatever platform we're using to try to conduct these virtual interviews. So be patient. Don't get caught saying something rude because your interview has been delayed or you're stuck in a waiting room. I mean, I think we all just have to be cognizant that everybody is doing their best. I'm probably a really poor example of this right now. I'm not in my own home. It's like very dark behind me. I had a child come on the screen, right? Like, those are things that you want to try to avoid in your virtual interview, but life happens. I think the other thing too, we've all seen some of those clips of like the news anchors at home who don't have pants on, and somehow accidentally the camera shows exposed legs. Like, I think it's a lot of the small things. I would definitely try to work on your internet connection to make sure that, wherever you are, you have a good signal. And if you don't, for whatever reason, like I have lived in one of those internet dead zones before, talk to your school. What can they do to help you? Do they have a room that you can sit in at school that you can reserve to do your interviews with a more stable internet connection? Because I think we all certainly understand power outages, storms, and things like that, but you want to really be able to, shine and connect well as well online, which is certainly a new issue that we are going to face.
I would add that if you have the ability to do an Ethernet cable and rather than relying to Wi-Fi. Wi-Fi is less predictable. And so if you have the ability to plug into an Ethernet, that's definitely probably preferable than relying on your Wi-Fi, since Wi-Fi is a little bit spottier. And then I think the other thing that you probably do on regular interviews is with a friend, do a mock interview with each other so that you can see if there's reverb, see if there seems to be spottiness, see, because you're not just talking about the content of the interview, but it's really hard for us to judge the content of the interview if we can't hear you. So I think that trying to make sure that that connection is correct. And then I love what Dr. Lall said of, if for some reason you don't have the ability to make sure that the tech issues are going to be appropriate where you live, then see what other alternative suggestions can be made, whether it's through your school, through friends, all the rest of it. Virtual background pro or for, I mean, I like my virtual background, but that's because I love the UW and I love my, I think it's a great opportunity. My kid and my teenage daughter and my husband built me a green screen at home. I can't do the green screen. I can't do a virtual background if I didn't have a green screen behind me that's literally 5 feet tall. So I don't really care if you don't have a green screen. I don't really care if I can see your, background, as long as I'm not looking at, I don't know, just think about what I'm seeing, because I'm learning a lot about you. And so I won't even suggest what some of the things that you wouldn't want me to see. I don't really care if it's a little bit of mess, but just make sure that I'm not seeing something that I really don't want to see back there.
And I don't think you want anything that's real distracting, because we're going to interview 1,000 people and we're looking for anything to, we're going to be tired and it's easy to get distracted. If you've got a giant bird cage with 2 parrots in the back, we may look at the parrots and forget what you're saying.
I do want to mention, though, the flip side of all of this, like talk of optimizing your tech and your background and everything, is that, we do understand that some of you have constraints, that whether those are geographic or technological or financial or whatever, on your ability to manipulate your setup. And I want to reassure you guys, there is literally not a human alive at this point in the pandemic who hasn't had their internet connection zap out during a Zoom call, or had a pantsless child run past in the background or whatever. Like, it's just part of life working at home. And it's part of our new reality. So if something does go amiss during your interview, please don't let it stress you out excessively. Your interviewers are going to understand and be fine, and will do their very best to help you get back on track.
We're impressed by people who can take things like that with a little bit of grace. It's going to happen every day at work. Show us that you can do it right now.
Thank you all. This is great advice. Now looking forward to the future. The SLOE has gone through many different iterations, including this year, to adapt to this changing and unusual environment that we are in. Speaking briefly, and I do think this bears relevance to applicants as they go into emergency medicine and may want to get involved into academia. If you could have it your way, how would you improve the SLOE? If you could have blue sky ideas and have the application process to residency be changed in any way to reduce stress, to allow applicants to put their best foot forward, what are some changes you would suggest, both to the letter, the SLOE, and to the process in general? And I'll open this up to the entire group. Or Dr. Morrissey can go, because his name is on the slide. So
this is the tough one, and I'm very excited to hear what you guys have to say. When Alexis posed this questions to us, he says, you can shoot for the moon on this one. And I guess if I had unlimited time and money, I would probably change the format of medical school and medical training such that people would do 3.5 years of medical school, and then a transitional half a year or a year before going into emergency medicine. And we would have our letters of recommendation built off a little bit more comprehensive experience, where we were watching people actually being a doctor. The problem with being a medical student is you're under some really weird constraints. And as an early intern, you're forced to take responsibility, and we get to see how you handle responsibility and how you bend and flex with those stresses. So I guess if I could, if I had a genie in a bottle, I would build a much bigger time frame for which I could observe you growing and build the slow off of that. Personally, I find a lot of frustration with the top third, middle third, bottom third categories, because what I see as top third personality, Dr. Jung may say, I can't handle that gunslinger in my place. And Dr. Gallahue may say, that's fine. And Dr. Lall's going, yeah, give me one of those guys. I can handle him.
I want quiet.
Yeah. So there's a lot of difference. So I've been trying to come up with ways to reformat the artificial linear structure of how we categorize people. My thought is more when I look at those parameters, be it communication skills, working as a team, taking responsibility, building a differential diagnosis and a plan, I see folks, the vast majority are either truly naturals at it, or this isn't their strongest suit, but they're just fine. They're going to need a little bit of guidance. And then there's the rare, oh my God, he's already attending level. And then there's the very rare, oh my God, how did he get into medical school? But the vast majority of those guys are either in an autopilot category or a little gentle guidance. A chance to work side by side with some good instructors is going to make this guy just fine. And I try and pick 2 or 3 of the categories that seem to be most autopilot, and 2 or 3 of the categories that seem to be most, this guy will need a little bit of nudging, and build my letters that way. So the Dr. Jung can look at it and say, you know what, I'm really good at teaching these 2 or 3 categories, and that guy needs work in those categories. This would be a great fit for me. Whereas Dr. Lall may look at it and say, we're not particularly good at teaching those 2 or 3 things. This guy might not be a super good fit for my program, even though he would be a good fit for somewhere else. So I'd love to hear other options, but I'm constantly thinking about ways to reformat the slow radio buttons, the slow spectrum that we use to rank people on, because I'm just not convinced that you can take 100 people and put them in order from 1 to 100 on personality.
I agree with that so much. I mean, it's sort of interesting to me that most people are going to fall on your bell curve, right? The problem is that when you have top third, middle third, bottom third, at least we can tell if people are being honest and where they're putting people. And in some ways, like sometimes it's okay if I see that most of their people are in the middle third and that they use the top and bottom third sort of more sparingly, because then I kind of know how to read that, and I like at least knowing what their categories are. I think if we were to try to put it on a bell curve, it would be hard to know if people were being honest. So I think really improving the SLOE really would be about faculty development. I think what happens is a lot of letter writers seem to think that we're looking for that everybody being attending level, everybody being top of their game. I wasn't. I know I wasn't. I was not like attending level by any means. I made so many errors as a medical student on my rotations. I guess I would, if I was to improve the SLOE, I mean, what I really want to see is I want to see faculty understand that we want a really rounded view of the person. There was one institution in the last few years where basically every single letter had one line for their narrative assessment, which said going to be, chief resident potential for every single letter. And I think I must have seen 13, 15 letters from that site. And it tanks my feeling. We're looking for reassurance, and that doesn't reassure me. I want to hear about who you are, pluses and minuses. I want to know where are your strengths and where are your opportunities for development, because you should be in process of development. If you're attending level, why are you going through residency ever? So I love knowing where we are going to start with you when you match in our program. We re-review all of that information when you match with us so that we can already start thinking about a plan for you. So if I were to improve the SLOE, it wouldn't be the SLOE as a form. It would be improving people's understanding that if you say that somebody needs work, that should be the expected. And I guess that's my hard part is, the grade inflation isn't just that. I mean, we see this in feedback where people aren't willing to give constructive feedback from faculty, where there's certain bias in evaluation. I guess where I was really, and maybe, I mean, when I talk about the blue skies, it would be really understanding that we want a fully holistic evaluation of a student. And please put some negatives in there, because I don't believe you if you tell me that this person is perfect, because none of us are. I guess that's that. If I had my heart of hearts, that's.
And I think to tag on to what both of you guys just said, I mean, Tom's point about sort of the bell curve, how the majority of students are like in this just fine pool. And then there are these tails, which are, really amazing and a little bit worrisome. I think I understand why we don't use that construct for the slow, and it makes sense to me. But I think that what gives me pause as a writer is knowing that if I put one student in the bottom third because they're in like my 30th percentile, and I put another student in the middle third because they're in my 40th percentile, odds are those two students aren't really that different from each other. But I worry that the reader is going to see that as a profound difference, as somebody I'm really worried about versus somebody who's solid, whatever that means. And I agree with Fiona. I mean, having a shared understanding of what this means and really getting through people's heads that less than top third is not a bad thing, that we should expect and embrace the idea that our students are not perfect and that they do have learning and development needs, which is why we have residency programs for them, would be a really refreshing and helpful thing that I think would encourage greater candor and decrease the amount of anxiety that students, and guess what, letter writers also have about the slow, because we live in terror that our honesty is going to be twisted around to mean something that's negative in an unintended way. And I think it would be so wonderful if we could all just sit down and agree that students need to learn things, and that's why you're called students, and that's okay and good and positive and fine. The end. By Jules. Thank you.
Yeah, that's why that narrative portion gets so vital. You can have 2 or 3 lower thirds and a couple of sentences in the narrative that says, with this kind of guidance, the student is going to fly right through that. And it's not a worrisome thing at all. 2 or 3 lower thirds with no narrative or a disconcerting narrative or a contradictory narrative, and all of a sudden the letter becomes really weird.
Thank you all. This is extremely helpful to our listeners. I think we've sort of covered this right now, changes to the slow going forward. I guess the one thing I'm curious to hear your thoughts on is, do you think some of the changes this year, and there's really no way to tell, but do you have a sense that some of these may stay, such as virtual interviews? Might we evolve to a time that virtual interviews may be provided as an option to applicants if they're unable to travel or to decrease costs? And what are some changes you've implemented this year that have been received positively, or you feel strongly about, that you think may be carried into the future?
I don't know, Lexi, I think it's still a little early to say what we think has been successful and what hasn't. I do think more than ever before, though, there definitely seems to be collaboration and cohesion in academic emergency medicine, and really trying to make sure that we are all on the same page, that we've laid out very realistic, expectations on both sides this year. And maybe we're informing each other a bit more than we normally would. And I always think increased communication is definitely a positive thing. But in terms of potentially always having options for virtual interviews or some of those other things, I think we all kind of need to wait and see a little bit. We spent a long time earlier talking about fit, and that fit is really critical on both ends. Because the programs in emergency medicine through the accreditation process are excellent. And it's really about finding the one where you thrive and where we can give you the resources you need. And not all programs look the same. You know, so I don't know that we'll ever really be able to replace that social interaction that happens when you're present in person at an institution on an interview day and for an interview social. We're a pretty, I think, gregarious group on the whole in emergency medicine. Like, we like to see each other. We have fun when we get to see each other at meetings. And that part is so important. So I don't know that we'll ever remain virtual only, but who knows?
I think that one good thing that's come out of the No,
you go. It's fine.
I was good. Okay. I think the one good thing that's come out of the pandemic is that we have learned how to connect with each other virtually in a more meaningful way. So I totally agree with Michelle. I mean, none of us want to see Zoom replace our real lives, but I think that there probably will be, like, what we'll learn from this is we'll have more opportunities for students to get to know different programs, to maybe target their application processes a little bit more intelligently, to get a better feel for the specialty, you know, even outside of the construct of the traditional rotation. Like, I think ultimately this is going to morph into better learning opportunities for you guys, both about emergency medicine content, but also about the field and different programs and residency training and what you should be looking for. So I think that that'll be a good thing. And maybe it will drive us towards what I see has been assigned to Dr. Gallahue here on this slide, which is talking about application numbers and, you know, getting students to align their application behavior a little bit more with reality, and not stressing themselves out by applying to 65 programs when they don't need to.
Yeah, I mean, it's interesting, you know, the ENT had a publication about signaling preferences, you know, so that you know, that there was an opportunity, like that, you know, and it was one way to sort of decrease the number of applications, but better target it to programs that people were specifically interested in. I mean, I would love to see things like that. You know, really, people should not be applying to as many programs as they are. You know, I think a lot of dean's letters are saying, like, you know, 50, and really it shouldn't be more than probably 36 for the average applicant. And it's just, you know, it's we have these different players in the field. We've got deans whose primary role is just basically get you matched, period. And that may cost you extra money. That encourages over application when they encourage you to have too many applications. It's really interesting. So I hope that we will be decreasing applications long term, so that you can target yourself to the right programs that are going to be the right fit where you thrive. Because it's you know, it's really not fair to students to spend extra money, and it's not fair to program directors to spend so much time reviewing applications if you're not interested in their program. You know, it's I think each person in the Venn diagram, we're not always aligned. So
just to give you guys some perspective, in last year's match, the average number of applications across the board for emergency medicine applicants was 49.5. So the average student is applying for you know, 50 programs, and students who perceive themselves to be at risk were applying for an average of 75. And we as educational leaders perceive a very small percentage of students as genuinely being at risk. Students, when they're allowed to self-assess that, are more in the 25 to 30% range, think of themselves as being at risk, and are grossly over applying. So, you know, that's something that does a disservice to everybody, right? Because it decreases the number of interview spots available for the average applicant. Because if the AOA kids think that they need to apply to 40 places and they're hogging 25 interview spots, you know, that's a bunch of interview spots that could go to normal applicants like me that I'm not getting, right? So we really would like to see better alignment between what students are doing and what they really need to be doing to get into the right program for them.
Maybe one of the things that is going to help us get to that endpoint is this year programs are scrambling to come up with online content that will help you get a better view of what our program is all about. In the past, we're angry that you can't pick your top 5 or 6 programs, but we haven't given you the information to really pick those top 5 or 6 programs. At this point, all you really know about different programs is where they are on the map and maybe a little bit of what you've heard. And perhaps the exercises that we're going through this year will allow all of us as programs to put out better content that will allow you guys at the end of third year and the beginning of fourth year to really pick your top 10 programs, target your applications, target your interviews a little bit better, and maximize your chances for matching in one of those good programs. I mean, I'm terrified that what's going to happen now that it's so easy to interview on Zoom is that all of the applicants are going to interview at 70 programs. And if that happens, the only logical response is for all of the programs to interview 500 applicants. And if we do that, that means all the interviews are only going to be a half hour long. You're not going to get to know us. We're not going to get to know you. And we'll be full circle to, why don't we just throw everybody's name in a hat and randomly allocate them? And that's not what anybody wants. But if we as programs and as you as applicants can't work together to find a way to limit that effectively, then I'm terrified that that's what we'll eventually get to.
I think though, Dr. Morrissey, that's a great point, that if as programs, we are trying to do a better job of really showcasing who we are and what we do and what makes us unique or stands out about our programs. And if we have more of that information on our websites, on social media, I think we really can work together for somebody to be like, you know, oh, I've always heard that Emory is such a great place, but I'm watching this video and this just isn't my style, you know, and that we say that's okay, you know. And I think seeing some of those, you know, little short videos or vignettes that I know our residents are desperately trying to put together so that applicants can have a feel for what we look like, I think would be tremendously helpful, much better than looking at a couple still photos on a website, you know, with a description.
Just to give everybody a little bit of perspective on interview numbers, the number of interviews that an EM applicant needs to have 100% likelihood of matching is 12. So if you graph the data with, you know, match percentage against interview number, you can see that the curve rises so you are more likely to match with each interview that you get up to 12, at which point it flattens out and begins to asymptotically approach 100. So students who are interviewing at more places than that are not increasing their likelihood of matching. They're just decreasing the likelihood of other students matching because those students aren't getting interviews at those places, which is, you know, really the basis. Just so you guys know, like in the consensus statement, which I imagine you guys are familiar with by now, we didn't pick that recommendation for 12 interviews randomly. We picked it because we knew that was an adequate number to get students matched. And again, our goal is to get as many students matched and get as many students a fair shot as possible. And also, of course, to make sure that programs fill, right? You know, we want that, the match is supposed to be just that. It's supposed to be a one-to-one, you know, marriage between a student and a program. And we want that to happen correctly. We don't want a small group of students hoarding too many interviews, because that leads to programs not filling and to bad outcomes and students not matching. And that's bad outcomes on both sides.
Just to put the, you know, because I know that as students, you probably don't have a whole lot of insight into the PD perspective, but programs don't have the capacity to have more interview days ad nauseum. It's not possible. It's extremely expensive to have this many faculty and, you know, taken out of their other work. And so the number of interview spots by and large have not changed, but what has changed is the number of, you know, so when one person who's particularly competitive interviews at, you know, some ungodly number like 17 of programs, those interview spots really are taken away from other applicants. And so if you are the average or above average applicant, and that means like most of you, that very few people are going to be sort of challenged or red flags. You know, the 12 works for programs and it works for students. When you take a lot more than that and you're not somebody who's in trouble or a match, you know, a couples match or something like that, it makes it doesn't only, you know, put us at risk for not matching in our programs, but it does take a spot away from somebody who might be really a good fit.
Thank you all for this. I think this is exceptionally helpful for applicants and hopefully alleviates some of the anxiety that is more this year. I would like to end by asking every one of you to share some pearls of wisdom, parting words, and advice for applicants. I'll just go ahead, going down my screen. I'll start with you, Dr. Gallahue.
So for most people who are not IMGs, not couples matching, or not having failed the, step 1 or failed a rotation, the ideal number of interviews is 12. The ideal number of interviews is 12, and one gold standard slow is enough. It really is. Parting words and advice, I think, take a deep breath. It's going to be great. One of the best things about the interview process is you get to know us, and we get to know you. And I do think that there's some really exciting things. Programs are innovating and really trying to create opportunities for you to get to know us. So, that's pretty cool. People are opening up didactics virtually in a way that they wouldn't have otherwise. There's more opportunities to hang out with faculty and residents. So that part of it's pretty neat. So take a deep breath, try to enjoy it as best you can. I know it's an anxiety provoking time, but you know what, you're going to do great. You will. And I think it's hard to feel that when you're anxious. But trust your advisors, trust people who get to know you, trust people who've looked at your application. Don't listen too much to the negatives. Don't listen to anybody who says you can't possibly match an emergency medicine because X, or, it's a great specialty. Rarely is a single thing going to tank your application. So please enjoy the process as best you can.
Dr. Jung?
Well, I agree as usual with everything that Fiona said. I think probably the two most important pieces of advice I give you is, one, please don't suffer alone in silence. The fact that you guys came to this event is a great sign that you're resourceful and you're willing to advocate for yourself. You're seeking out additional information. There are lots of advising resources out there. RAMS can help potentially link you to people. EMRA can help link you to people. CDEM is working on developing a formal advising program for orphan schools. So I've literally spent the week personally emailing the student affairs deans at every orphan school in the country that we're aware of to try to make sure that students are aware that this is a resource that's available. So just don't hesitate to reach out to whoever you can and ask questions, get put in touch with people, and get help, because you shouldn't have to go this alone. This is a difficult time. And if you have questions that weren't answered here or in other venues, there are lots of people who are perfectly willing to talk to you, myself included. The other piece of advice I have for you is just compassion. Keep your compassion well deep, and always remember compassion for your patients in the hospital, for your teammates. Remember that medicine is a profession of service, and we should be there to serve our patients and to serve one another and make our patients' lives better and our own jobs and each other's jobs easier. But most importantly, have compassion for yourself. Don't perseverate on how you got a 220 and you wish you'd got a 240 on step 1. Don't perseverate on how you got a pass in surgery and maybe you should have honored. Just recognize that you are where you are, and that where you are is good enough, and that 37 of us on this call are in the bottom third, and we're all going to be great emergency physicians.
Thank you, Dr. Jung. This was great. Dr. Morrissey.
I agree. What's going to make you great is your training, not where you've been, but where you're going and the attitude you take as you go there. Which brings me to my point, which is don't sweat geography that much at this point. I know people think, oh man, I went through all of this training and then I went through all of medical school and now I'm going to move to my dream place and I'm going to settle down and everything is going to be fine. You're not quite there yet. What you get out of residency is so dependent on the comfort of the fit. And you're going to spend way more time inside the hospital walls than you are outside. So if your dream is San Francisco or Denver or Atlanta, you can go there and then you're 3 years are going to go by and you won't have seen very much of it. And if it's a discordant fit, residency is going to be really tough and you're not going to get a lot out of it and you won't have set yourself up for success. Whereas if you go to a program that is a good, comfortable fit, and I'm sure Alexis can attest to this, no matter how cold it is, he's going to be inside the whole time.
That is very correct. Thank you, Dr. Morrissey. Although I will say the beaches in Jacksonville are a big selling point. Dr. Lall, you're next.
Yeah, I mean, I certainly agree with everything everyone has already said. I think the other thing that I would ask of you is to be memorable. You only get a couple pieces of your actual application that you can impact directly. And one of them is your personal statement. Tell me something interesting. Don't just tell me that you were on the medicine rotation and you heard the code blue and you went with your team and it was so exciting to see this organized chaos around a dying patient. Please don't. Okay? We have all read that personal statement hundreds of times. Tell me something about you. Tell me that you have 6 brothers and sisters. Tell me that you grew up on a farm. Tell me that your parents are that you're a first-generation American. Tell me what your favorite food is or what you like to cook. Tell me something so that when I read that piece of your application, I see a piece of you. Like, really, I think for me, that's always my favorite part to read is the personal statement. And do not lie, Dr. Morrissey put in the chat. Please don't tell me any lies, but just tell me something interesting. Let me know who you are. And I think you've heard us all say, that we want to see these other sides of you, who you are as a person. Your evaluations, you're slow. They can tell me who you are as a growing clinician, but this is your chance to tell me who you are as a person and how you want me to remember you. So really be thoughtful about your personal statement and please have somebody proofread it. Please, please, please. That's my only additional advice.
Thank you, Dr. Lall. This is very helpful. And I would love to end with a quote from one of my mentors who said to me throughout medical school many times, have for yourself the grace that you have for your patients. And if we can leave our audience with this, that it's going to be okay, it's going to be all right, but please treat yourself with grace and kindness. Couple special thanks. I would like to thank Kat Nagasawa and the entire SAM staff. It takes an army to create a webinar such as this one, advertising it, disseminating it, and assembling our panel together. I'd like to thank Dr. Andrew Starnes, who is our RAMS board esteemed president and involved me in moderating this event. A couple plugs for SAM and RAMS. Anybody who's on this call, including your friends, we would love for you to get involved with SAM in our committees. You can apply to be on SAM committees every spring, but throughout the year, we can always use help. I'm on the virtual committee. We have many initiatives for which we need medical students to help us, including increasing our Twitter coverage and involvement. And you don't necessarily need to be in the committee for that, but you can still get a title and you can get connected with some of the leading voices and mentors in emergency medicine. So you can reach out to myself or Kat or any of the other contacts on the SAM website to get involved in this new learning environment where perhaps you don't have as much clinical experience. That's another way to stand out and show your commitment to emergency medicine. I've mentioned this before, but I want to mention it again. The SAM Virtual Residency Fair is July 27th through the 30th. You can sign up now on the SAM website. We have greater than 100 programs that have signed up. And hundreds of students as well. This is truly an exceptional opportunity for you to get to know programs and put a face to a name and put yourself out there for APDs and PDs to get to know you. And then finally, of course, I would like to thank all of our panelists tonight. I thought this was a great conversation. I felt, I'm not even applying and I feel better. I just have butterflies. I'm like, oh, it's gonna be okay. But sincerely, I wanna thank you all. You have provided exceptional insights and tips to our listeners. And this will live on as this is recorded, and hopefully many more hundreds of applicants will be listening in to the recording. We only have a couple minutes left, and actually our panelists did all an exceptional job of replying live to many and most of the questions in the chat. So I think most every question has been answered. Once again, I thank you all, and please, to our panelists and our audience, stay safe, wear your masks, practice social distancing, and Zoom away. Thank you all, and please all have a great night.